Yeah, live, sir.
Good evening. On behalf of faculty, residents, and staff of Department of Radio Diagnosis, AIMS, New Delhi, I welcome you all, including our IRIA, ISVIR colleagues and members. I also welcome Dr. Isha, wife of Dr. Anoop, and other family members. Anoop was very dear to us. We all have fond memories of him. As said by someone, life moves on, but memories stay. Dr. Sudhakar, good morning. It is 6:30 a.m. as you told me. Nice to see you after a long gap, and happy that in a few minutes we are going to hear you on a very, very important topic, which is a global health concern problem. Now over to Dr. Rajik to tell about Dr. Anoop.
Good evening. Today we are here to honor the illustrious life of my dearest friend and AIMS alumni, Dr. Anoop MK, on his birthday. The Sanskrit meaning of Anoop is incomparable and unequaled. How very apt. For not only was Dr. Anoop one of the finest radiologists that this hallowed institute has produced, Anoop, as we fondly called him, was above all an incomparable human being, unequaled in grace and humility. His exuberance shone out from his mischievous eyes and infectious grin. A thorough family man, a brilliant diagnostician, a beloved student and colleague, an ardent footballer, and an avid traveler, Anoop's life was all about passions. His battle with leukemia and untimely demise has left all of us deeply saddened. His loss is irreplaceable. Our hearts go out to his family in this time of grief. And yet we must carry on, for that is what Anoop's indomitable spirit has taught us to do. No, Anoop, you're not gone. Our victories are your victories, for we all carry a part of you within us. Henceforth, you will continue to live on through our accomplishments. We hold you close within our hearts, and there you shall stay forever. Next, I request Professor Raju Sharma to take over and introduce the speaker.
Thank you, Razik. Your friendship was indeed legendary. Anoop had a brilliant academic record. His amicable and humble demeanor was the reason he was loved by all. Born and raised in Kasaragod in northern Kerala, his stellar academic achievements included rank 1 in class 10 board exam, rank 4 in class 12. He graduated from the Calicut Medical College and then joined radiology at AIMS and was awarded the Shyam Sharma Gold Medal for being the best postgraduate. This brilliant journey was sadly cut short on the 28th of August, when his untimely demise shook us all and left us grieving for our brilliant friend and colleague. He fought a valiant battle against leukemia at the Tata Memorial Hospital with unwavering family support of his wife, parents, and brother. As a humble tribute to his memory, the department unanimously agreed to initiate the Dr. Anoop Memorial Lecture to be held on his birthday every year. To deliver the first lecture in this series, we have invited Dr. Sudhakar Pipavath, another one of our brilliant alumni. He's a professor of radiology and director of pulmonary imaging at the University of Washington in Seattle, USA. He joined AIMS way back in '91 as a young undergraduate and then went on to do his radiology residency. He has trained at the University of Colorado in Washington, and he has fellowships in thoracic, body, and neuroimaging. Sleepless in Seattle, Sudhakar has been working tirelessly during the current pandemic, resolving the imaging conundrums of this very complex disease. His clinical interests include interstitial lung disease and lung cancer. He's a well-known speaker at meetings in the United States as well as back in India. I welcome Dr. Sudhakar to share with us the lessons learned in COVID-19 imaging and show us the road ahead. I'll hand over to the two moderators of the session, Dr. Deep and Dr. Ashu, who will also coordinate the Q&A at the end of the session. Welcome, Sudhakar.
Thank you.
Good evening to all. And the question and answers can be typed if you are on YouTube in the YouTube chat. And if you're connected to us through Zoom, in the Zoom chat box, we will compile the Q&A and take them after Dr. Sudhakar's talk. Now, we hand over to Dr. Sudhakar, please.
Thank you, Dr. Bala. Are you all able to see my screen in full?
Yes, we can.
All right, perfect. Thank you. Thank you. It's an honor to be here and deliver the first Dr. Anoop Memorial Lecture. And thank you, Dr. Raju Sharma. Thank you, Ashu. Thank you, Sir Dr. Deep. And thank you, all the organizing committee members. Okay, without further ado, I would like to start this talk because we are on a kind of a strict timeline. So I've changed the title a little bit. I've taken some liberty here. I just said simply understanding COVID-19 because I still am struggling to understand what exactly this particular disease is. And in order for us to understand, we have to kind of look at how we do things, first of all. In day in and day out, how do we diagnose cases? We look at an image, and if it's, sometimes we say it's an Aunt Minnie and we don't listen to anybody. At that time point, we say it looks like a duck, it walks like a duck, it must be a duck. And then, but most often is what we have to use what is called the probabilistic approach. So in which you have a pretest probability below which you have a test threshold for a pretest probability, above which you test somebody, below which you take it that that individual does not have that particular disease. So with that background, let me start by stating the objectives of this talk. I'm going to try and give you some glimpse on understanding the pathogenesis of ARDS, which will help you understand the severe form of COVID-19 that we see in some patients, and learn some aspects of choosing the correct test, and also consider trying to come to understanding about imaging phenotypes in COVID-19. I'm saying that with a little bit of reluctance because we don't have enough data to really phenotype at least the initial imaging patterns. And also just have a quick glimpse as to what might happen once this pandemic is over in terms of what we should expect, what types of lung diseases should we expect. So lung is an interesting organ. If you look at the lung or the gas exchange unit, it has a really simple footprint. It has very few cells. It has the type 1 pneumocyte, type 2 pneumocyte, and the alveolar capillary membrane and the endothelium. And then it relentlessly, in health, it delivers excellent function, which helps the entire body. But when it is stressed or when it is injured, it has very few ways it tends to respond and repair. And one of the simplest things that it does is it starts pouring in this proteinaceous rich fluid into the alveolar space and tries to heal itself and then get back to function. And when this is happening, it goes through a phase of a leakage of fluid, it goes through a phase of organization of fluid, and then either the fluid is cleared or it may get cleared by the process of the usual healing methods, which is what we generally call as fibrosis. And during this entire process, unfortunately, the gas exchange unit cannot take leave or assign its job to somebody else. So, which is what is the struggle often with ARDS, that you have to give good support and maintain gas exchange and do whatever you can so that the body continues while the lung heals. And in majority of the patients, when you have injury to the lung, it, through a simple repairing mechanism, it moves towards health. But depending on the host factors, depending on the negative host factors, it may take a circuitous route through responding by organizing pneumonia and then moving towards health, or it can be a little bit more damaging in the form of acute fibrinous organizing pneumonia, in which you have an element of slightly higher amount of acute lung injury and equal amounts of organizing pneumonia. And then the problem with, as these responses start happening, the probability of moving towards health may not be 100%. So you may have to deal with a bad outcome in some situations. And then we are all familiar that ARDS, nowadays with improved treatment, is probably 1 in 3 individuals don't do very well when they get ARDS if you take all comers. But originally, even until mid 90s, it was a 50-50 chance. If you have ARDS, the probability of dying was high. And partly the outcomes may have improved because we have changed the definition to include some milder variety of ARDS in here. And what is it that determines whether we move straight to health or take the circuitous route? Often depends on the host factors. If somebody has a damaged lung, they may respond, they're more likely to respond with either organizing pneumonia or ARDS or something else. And you will also see this particular thing play a role in etiopathogenesis of UIP, IPF, in which it is not the injury or the inflammation, but the way the lung decides to respond or heal relentlessly because it cannot sense that there is an end to the injury or there is an end to the repair mechanism. So with that, I move towards ARDS. And within ARDS, there are several phenotypes or subphenotypes. And the quote below here says, all are damaging, but some are more thrombotic, and which partly explains why we are seeing different outcomes in COVID-19. And if you look at ARDS, the pathologic correlate of ARDS, ARDS is a clinical diagnosis, whereas the pathologic correlate is what we call diffuse alveolar damage. And diffuse alveolar damage has 3 distinctive phases. One is the exudative phase, we have the proliferative phase, and the fibrotic phase. And typically the exudative phase is the earliest, peaks within 1 or 2 days, and then can last up to 7 days. And the proliferative phase typically starts around the 4th day and can go up to 10 days. And then after the 7th day, typically we start noticing that the fibrosis has set in. And what exactly happens is if you look at the alveolar exchange unit, all the 3 important cells here become dysfunctional, meaning the type 1 cell is injured and denuded and is detached from the basement membrane. Until that is fully restored, we will not call the repair process complete. Then we have the type 2 pneumocytes, which play an important role in the day-to-day function of the gas exchange unit. And the endothelium, if it is injured, it can lead to problems, as we know. What exactly happens? So endothelial injury leads to leakage of fluid. Epithelial injury and denudation of the type 1 pneumocytes happens because of all the inflammatory cascade which is set in, which is also the reason for the endothelial injury in the first place. And then until this repair is done, none of these things get restored completely. Then we have the type 2 pneumocytes, which we often, if you look at the microscopic images, you'll often notice balloon pneumocytes. Initially, they were thought to be only in the setting of chemotherapeutic agent-related injury. But nowadays we know that the type 2 pneumocytes are ballooned and enlarged and dysfunctional in almost all the forms of ARDS. And if the type 2 pneumocytes are not functioning well, they're not going to produce an important substance, which is a surfactant, which leads to alveolar collapse, and which means that the ventilation will be impaired, meaning, and then if there is, as we know, there is endothelial injury that can lead to fluid leak and increased perfusion. So clearly we know from our physiology days that when these two things don't match, we are in trouble. Which is also partly the reason why proning the patient is an important strategy, because it tends to reduce the shunting of the blood and also reduce the mismatch of ventilation and perfusion and reduce the dead space. And which brings us to the COVID-19 situation. Within the COVID-19 ARDS patients, as this particular study mentions, we have a hypo-inflammatory subphenotype and a hyperinflammatory subphenotype, and which is guided by the presence of all these inflammatory cascading substances such as IL-6, IL-8, and TNF-1. And if these are elevated, as we have noticed, the mortality is high and the number of ventilator-free days are low. And unfortunately, all of us are now familiar with these terms. And what is it that some of them have a hypo-inflammatory subphenotype as opposed to a hyperinflammatory subphenotype? And again, unfortunately, we have become too familiar with the fact that the underlying host conditions are what are extremely important. And things like diabetes, things like male gender, things like elderly individuals are not doing well. We all know that. And then there are other situations too, like if somebody's underlying lung reserve is not good, they're not going to do well. And if they are at a risk for much severe injury because of their immune status, they're not going to do well. And in our experience, our ARDS patients or patients who died, we did not see a high number of individuals with a prothrombotic phenotype or subphenotype. The number of individuals who had microthrombi at autopsy were no different than what we would expect from ARDS from any other condition. So typically we expect to see this in 1 in 5 or 1 in 4 individuals. What we noticed was mostly diffuse alveolar damage, and we also saw some large reactive type 2 pneumocytes. And here's a set of images kindly given to me by Dr. Marshall. And you notice that these 3 phases at the microscopic level, you notice intraalveolar fibrin at the time of early diffuse alveolar damage. Then we start noticing these hyaline membranes. And then in the fibrotic phase, we start noticing these loose fibroblastic foci. If those of you who are interested in interstitial lung disease, you know that this appearance is an important feature in the diagnosis of UIP. What it means is that you're moving from acute lung injury to almost a fibroblastic process over a short period of time, which generally happens over many years in the setting of UIP-IPF. And if you look at the images downstairs here, these are the ballooned type 2 pneumocytes. See how big they are, and they become dysfunctional. And then here's an example of perivascular inflammation, and this is an example of multinucleated giant cell. And although in our series, we had really few patients who had microthrombi, here are some examples of platelet microthrombus, fibrin microthrombus, and perivascular inflammation published in Lancet by our pathology group here as a Washington State case series. And then, which brings us to an interesting question, which is addressed by, partly addressed by Ackerman et al., as to what is it that makes COVID-19 related subphenotype, which is different from other causes of ARDS. So just as a guidance to these images, this is how a healthy capillary network looks like in a healthy lung. And this is what happens when you have ARDS or diffuse alveolar damage and endothelial injury. And what they noticed was once the endothelial injury is done, there is angiogenesis in all patients with ARDS. But what they noticed was that in COVID-19, it is the intussusceptive variety of angiogenesis, which was more common and associated with increased hospital number of days in the hospital. And just so that you know, there are two types of angiogenesis which are described, sprouting and the intussusception type. And this is the type that is described more often in COVID-19 or individuals who have severe COVID-19, I should say. And they correlated this with the type of angiogenesis with the number of hospitalization in days, and then clearly shows that there was a direct correlation with increased amount of intussusceptive type of angiogenesis. The number of days of hospitalization went up substantially, as opposed to in other conditions, they use the control of influenza, healthy controls, and NSIP. In them, they did not see intussusceptive type of angiogenesis. It was more of a sprouting type of angiogenesis. And as we all know, development of ARDS and progression from ARDS to death in COVID-19 depends on the host factors. And it might be, we also notice that it is not just the lung dysfunction which drives mortality, but dysfunction of other organs, which is reflected in serial organ failure assessment scores. As the SOFA scores go up, the probability of death goes up. And here's an interesting study which speaks to this fact, which is now quite obvious to most of us, where they looked at various vascular risk factors such as hypertension, diabetes, dyslipidemia, and the other host things. And then they noticed that as the number of risk factors increase, the probability of severity of COVID-19 event goes up substantially. And from here on, I'm going to change gears a little bit and then look at the other important question, which most of us radiologists had to answer in the last few months. And I would be doing a disservice if I don't mention this particular letter to the editor, which is a interesting read, and in trying to understand the value of diagnostic tests and how they should be used. And in order to understand this, we need to understand what is called the threshold model. What exactly is a threshold model? It is basic. This is saying probability of a particular disease, 0% probability to 100% probability. We know that no matter what we do, it is very difficult to achieve 100% probability. So we try to come to a consensus about beyond what treatment threshold of probability, meaning let's say if there is a 90% post-test probability, then we will go ahead and treat that particular individual as having that particular disease. But at the same time, the other end of this threshold is called the test threshold. So what is the pre-test probability above which you feel comfortable doing a test so that you can try to push it above the treatment threshold and start treatment? But if the test is negative, you want the post-test probability to fall below the test threshold so that you can tell the individual that you do not have this particular disease. And in COVID-19 and in many diseases, we accept 5%. If it is below 5% post-test probability, we happily say that this individual probably, this is an acceptable probability to say that you or that particular individual does not have COVID-19 infection. And which brings us to this interesting point. So this is the 5% post-test probability. So it depends on the test itself, and test has an inherent positive and negative likelihood ratio, and which depends on the sensitivity and specificity of that particular test. But how do you make sure that a particular test, when negative, gives us a post-test probability less than 5%? It really depends on the pretest probability. So if you reduce the pretest probability, a poorly performing test, a test with a relatively lower negative negative likelihood ratio can also lead to a 5% post-test probability. But if the pretest probability is very high, you need a very specific test for you to reach less than 5% post-test probability. So I know I'm using these terms quite a bit, and it might be a little bit confusing. So let's look at it a little bit more with some infographics. So just to start with the RT-PCR, which is an important test. And if you look at the RT-PCR, this is the initial publication, which gives us a sensitivity and specificity of approximately 77% and 98%. And as the time passed, I think the general accepted number tends to be 70% and 95%. And some places have developed their own tests, and they've checked for their own sensitivity and specificity, and these numbers may vary a little bit, but more or less it hangs around this particular number. So how does this pan out? Let's look at this particular graph, which is plotting post-test probability on the left side, pre-test probability on the right side, and a test that has 70% sensitivity and a 95% specificity, right? So this is our current RT-PCR test. If you have this test, you need the pretest probability of less than 15% for your test, or this particular test, when negative, for it to be at or below 5%. Does it make sense? And you will get more leverage in terms of pretest probability if the sensitivity and specificity of your test go up, which means that if you, let's say, if you have a test that is 90% sensitive and 95% specific, then you have leverage in terms of accepting a pretest probability of up to 35%. And this is, as you know, this will vary. The pretest probability will vary from location to location. Say, for example, in Telangana, it'll be really high. In Andhra Pradesh, it'll be really high. In Tamil Nadu, it was really high. But in certain other states, the pretest probability, driven partly by the prevalence, was low. So the whole idea is to reduce the pretest probability so that our tests can do a better job. So this is an interesting interactive tool which is available at the British Medical Journal website. It is called the COVID-19 Test Calculator. And I've used a pretest probability of 18% just to show how various tests perform when you plug into this particular calculator. So if you take the RT-PCR, which had a test sensitivity of 77 and test specificity of 98%, and if it's a negative test with this pretest probability, you can reach a 5% post-test probability or lower, and that will help you tell the individual that if the test is negative, you do not have COVID-19. But if the test is positive, the probability of having COVID-19 if test is positive is 87%, which is decent. It is, anywhere close to 90% is pretty decent. And then you can go ahead and start treating that individual as having that particular disease. So with pretest probability at 18 or below, I think our test seems to function really well. And which means that the key then ends up being the pretest probability. So here's an infographic example. Let's say the pretest probability is 80%. And these are 100 people at risk of developing COVID-19. And if the pretest probability is 80%, then 80% of them have COVID-19. And let's say you use RT-PCR assuming a 70% sensitivity and 95% specificity. I rounded it off a little bit as suggested in this particular article. And if you do that test, then you will have 57 individuals who would have the test positive, and 43 people will have a test which would be negative. So then the question is, who actually has COVID-19? And if you look at this, you'll notice that 56 people who test positive have COVID-19 are true positives. And accordingly, the consequences that you request them to self-isolate. And if they have severe disease, then we go on to do additional management. But there will be one person who would test positive, but does not have COVID-19, which would be the category of false positive. And you've asked one person to self-isolate when they do not have COVID-19. I think that is an acceptable number. But what is unacceptable is the 24 people who test negative have COVID-19. And then they are told that you do not have COVID-19, and that can lead to a problem of increasing the R naught, or they may go out and infect other individuals if they do not isolate. So which leads us into this important question, which we all have grappled with, is CT or no CT? And we all by now understand that CT is not a great tool for screening for COVID-19 infection, whereas diagnosis of COVID-19 lung disease in individuals who are suspected of having COVID-19 lung disease is another matter, and which falls under the category of diagnosis of lung disease in the setting of COVID-19 infection. And it's a no-brainer that we are going to use imaging as much as possible once a patient gets admitted, meaning management of lung disease, depending, looking for lung complications and stuff like that, we have to use imaging. And interestingly, we have a natural experiment, unfortunately, a natural experiment which we noticed in the Diamond Princess cruise ship episode, which was docked in Yokohama, Japan in February, and more than 700 of the 3,700 people tested positive for the coronavirus. And what was interesting was that 331 of the positive individuals were asymptomatic. And of these 331, 76 of them had a CT scan. And of the 76 who had a CT scan, 41 of them had abnormalities at CT, which kind of gives us a glimpse into what to expect when we do a CT scan in individuals who are asymptomatic but are COVID positive, and which is almost 50%, assuming or ignoring the sampling error for now. And which segues us into this particular study, which was done in China at the beginning of the pandemic. And this particular study looked at the role of chest CT and compared with RT-PCR. And unfortunately, as we have already seen, RT-PCR by itself is not a very good gold standard study. So, but still, using RT-PCR as a gold standard, we have a sensitivity of CT that was reported to be 97% in this study, but the specificity was really low at 25%. And what this means is that again, going to this particular COVID-19 test calculator with a pretest probability of 18%, if the individual and the test sensitivity of 97% and test specificity of 25%, if this individual has a positive test, there is only a 21% chance that probability of having COVID-19 if the test is positive, although it tends to do well when the test is negative. If the CT is negative, the probability of having COVID-19 is 5% or less, again, depending on the pretest probability. But it doesn't do very well, which is an important requirement for us if we truly want to use it as a screening tool. I meant it doesn't do very well in picking up the true positives. And this is another calculator that you can use and play with the numbers if you are trying to handle this particular question. Which brings us to the next question. Most of you must be thinking, what about chest radiographs? And chest radiographs, although this particular study mentions that there is a characteristic imaging or the radiographic appearance for COVID-19, and those of us who read radiographs day in and day out, we know how flawed that particular statement can be. Because in this case, they're suggesting that presence of peripheral opacities, either ground glass or consolidative opacities, are characteristic for COVID-19. But obviously, if the pretest probability is high, then it might help. But if the pretest probability is low, then it would be, you can't really differentiate it from other causes of diffuse lung diseases. And this was published in Cardiothoracic Imaging Journal, or the Subjournal of Radiology, which is a brand new journal. If you're interested, you should send some papers here, because this is quite popular now. And this particular study came up with a sensitivity and specificity for chest radiographic findings of COVID-19 to be 15.5% and 96.6%. And when you plug in to the test calculator, how does the chest radiograph perform? Again, I put it at 18%. It does really well when it is positive. But if the chest radiograph is negative, then this is a big problem. Again, this can lead to a lot of problems. So effectively, I think amongst the tests that we have, RT-PCR seems to do a decent job, because it gave us a 5% and 87%. And these two are, as we know, sensitivity and specificity are, as the sensitivity goes up, specificity goes down, and vice versa. We know that already. And with those things in the back of your mind, I think RT-PCR is a very decent test for us right now. And again, the best approach for us is to reduce the pretest probability. And reduce the pretest probability, reduction of pretest probability generally depends on policy decisions, and whether we decide to do a lockdown, whether individuals are more disciplined in wearing a mask, or even wearing 2 masks, and hand washing, social distancing, the entire scenario that we are way too familiar with right now. And what is the role of imaging in the setting of assessment of ARDS? So if you look at the Berlin definition of acute respiratory distress syndrome, which is most commonly used, in terms of chest imaging, although it says chest imaging, it is generally a chest radiograph, because it is much more convenient to get a chest radiograph than getting a chest CT scan. Although, it is left open, as you can see in the subscript here. What it says is looking for bilateral pulmonary opacities, which are not explained by other causes, such as pleural effusions, lobar or lung collapse, or large nodules or masses. So that's pretty simple, I think. And the other thing that you can do, which is a well-established score, especially if you want to assess the severity of disease, is what is called the Rayleigh score, which stands for Respiratory Assessment of Lung Edema Score. And in this situation, what you're doing is you're dividing the chest radiograph into 4 quadrants and scoring it for extent and density. So if it is involving less than 25% or more than 75%, so it is basically divided into 25 to 50, 50 to 75, and more than 75% for extent. And for density of consolidation, it is a subjective assessment of hazy, moderately dense, or substantially dense. And this is a pretty decent score, which is used worldwide to assess severity of disease on the chest radiographs. And changing gears again and coming to the last phase of the talk, which is discussing some of the imaging phenotypes, or I'm not even sure if I'm allowed to use that term because we haven't fully established. This is quite anecdotal, and we don't have any papers clearly binning these imaging phenotypes or whether these imaging phenotypes have any predictive value. And I'm going to show you three common phenotypes which we are noticing. One is which is quite intuitive, where you have a diffuse ground glass opacity which moves towards organization and more organization in this particular patient who had several risk factors, including hypertension and diabetes, and was a 70-year-old male patient. And here's a more common or not common, I'm not sure how common this is, more characteristic description that we have heard of, which is involving the peripheral portions of the lung. And one of my residents actually described this as bull's horns. And as you can notice, it likes to affect the dependent peripheral portions of the lung and relatively spares the anterior peripheral portions of the lung. But as the disease progresses, even this one will affect most of the lung as it goes through various phases of ARDS. And the last subphenotype is where you have peripheral lung abnormalities, as you see here. But these tend to be discontinuous, meaning they're more patchy but peripheral. And unfortunately, even for these individuals, as the disease progresses, it becomes or transforms into a more diffuse process. And you can see that there is traction bronchiectasis already, which has set in on day 7. One could say that maybe this is a reflex dilatation, but reflex dilatation typically does not give you this kind of a varicosity that we are noticing in the traction bronchiectasis itself. And by day 10, you clearly notice that there is a probable surrounding fibrotic phase of disease, which is causing traction bronchiectasis and maybe even bronchioloectasis. And what do you guys think about this particular individual? Do you think this person has COVID-19 or no? This particular individual, although has these peripheral ground glass opacities, and in the current clinical scenario, we would be forced to investigate the presence or absence of COVID-19 infection. But this was from an earlier time when we had H1N1 epidemic here in the United States. And again, look at the similarity of the abnormalities. So partly the pretest probability being high makes us, helps us go down the path of saying that if there is any lung disease, you need to kind of make sure that it is not COVID-19. And these are some of the imaging phenotypes that we have noticed. And I think those of you who are in India are better placed, fortunately or unfortunately. There was more CT imaging done in India. And if any of you have access to that data, assessing that and looking to see if there is any predictive value for these sub-phenotypes might be a useful research possibility. And we all know that, and we all have realized that it is the second week where the severity of lung disease is substantial, and which is also reflected in this particular study, which charted lung changes at CT over a 25-day period. And you can notice that the most severe disease is seen anywhere around 10 to 12 days. And coming to the last segment of this talk, I myself don't know what to expect once things slow down, and I'm putting, I'm going to show you what we have experienced in a few cases, and one of the example that we have seen here. And although it is a little bit early to say for sure that this is how you need to investigate individuals who are survivors of COVID-19 interstitial pneumonia. But I think Dr. Ganesh Raghu and Kevin Wilson have published a comment in Lancet Respiratory Medicine, which gives you some guidance, although this is a document that may change as time passes. And I'll end with this interesting example that we had. This individual had COVID-19 in March of 2020, and then he presented to us in May of 2020, and you can clearly see the areas where he had lung disease have now transformed into a fibrotic disease, as seen by coarse ground glass opacity and underlying reticulation and a hint of traction bronchiectasis or bronchioloectasis. And then when this patient presented this time around a few weeks ago, you actually notice that it has evolved into a substantially fibrotic process, as seen as evidenced by clear honeycombing in some of these areas. And unfortunately, one of these cysts actually ruptured and patient presented with pneumothorax. And while in the hospital, once we treated the right-sided pneumothorax, there was a pneumothorax which developed on the left side, which I'm not showing here, but which gives us some understanding as to what might happen in a decent percentage of individuals as the time passes once they return to the pulmonary medicine clinics. And last but not the least, this is what we have been following here. ACR recommends that CT should not be used for screening. It should be used sparingly for hospitalized patients, and facilities may consider portable radiography units, even in the ambulatory facilities, so that it might be easier and quicker from a logistics standpoint. And we have also done what are called, we have developed a protocol for doing radiographs through the window of the ICU. I guess it is not exactly applicable in India because of the way the ICUs are structured in India, as opposed to in US. I think you can do this, which we have done and has been quite useful. And even though we discourage doing too much of CT, it is important as radiologists for us to understand and familiarize ourselves with the CT patterns. And for those of you who are in India, this is a wonderful document and developed by Dr. Bhalla and her subspecialty group for chest radiology as part of the Indian College of Radiology and Imaging. And, thank you very much. And this is a wonderful guidance document and very well thought out. And if you follow this, I think you would be doing what we all are proud of, which is evidence-based medicine. And with that, I would like to thank you for listening to me patiently as we migrate from unknown unknowns to known knowns, as Donald Rumsfeld infamously said before going into Iraq. Thank you very much.
Thanks, Sudhakar, for a very lucid, fruitful, and what I can say, you have taught us a lot of stat and infographics, etc. and all. In the meantime, till we get questions from YouTube and other sources, myself and Dr. Ashu will ask some questions, not questions, in fact, interactions. So, as you have already said, that ARDS, Berlin definition, and clear-cut indications, bilateral opacities, unexplained by other findings like pleural effusion nodules, etc. Sometimes clinicians ask us to differentiate COVID versus some other infections like tuberculosis, as you know, is more common here. So, in cases of ARDS in admitted patient, can you tell something about that, the imaging utility? How often you do to differentiate these things, and what should we focus on?
So I think unless the imaging patterns are quite characteristic, I think what really determines how we all know that imaging patterns of only certain infections are pretty characteristic, whereas other medical radiologic diagnoses have a lot of overlap, which is why I emphasized on the probabilistic approach. And I know, having been at the parent organization in Delhi, having worked there and being there part of that family, I know there are several logistic challenges. How quickly we move from doing sputum testing towards being more invasive if we are not sure, and doing a wide array of PCR tests on bronchoalveolar lavage fluid. The immediacy with which we do here may not be possible because of some logistic issues in our parent institution, and which is when obviously the referring providers might rely a little bit more on what we think is the likelihood infection as a radiologist. And obviously, in those situations, the group that makes decisions about the patient typically comes together and makes a working diagnosis. You have to take a call. And unfortunately, as the famous painting tells us about blind men and the elephant, it is always a collective effort. Unless we pool our resources and our individual sensitivity and specificity, each of us, if you look at a radiologist can act as a lab test and can also act as a consultant. So sometimes we are expected to be a lab test sometimes, and sometimes we are expected to be a consultant. And in order to make a final diagnosis, it's always good to be at the table and make a diagnosis together rather than rely on a single piece of information. I hope that answers some of your part of your question.
Very much.
Dr. Deep.
Ashu, please continue. Yeah, thank you.
Yes, Sudhakar. So thank you. It was a very enjoyable talk, and it actually brought out that nobody has all the answers in science, and especially so in COVID. My question is again, I'll ask you 2-3 questions. One is related on diagnosis, follow-up, and post-COVID fibrosis. So on diagnosis, taking forward what Dr. Deep already asked you, that patients of SARI who are admitted, particularly immune-compromised patients, COPD, in a community, if you diagnose COVID in RT-PCR negative patient, it's all right to admit, isolate. But if the RT-PCR is negative and your pattern is suggestive, would you really go ahead and use the specific antivirals for COVID-19? Like, would you give remdesivir or plasma, or based only on imaging? And especially because there's so much, use of steroids, which you probably may not do in other infections. So how far would your MDD really treat empirically on the basis of, especially for India, H1N1 was not an epidemic. It's like a recurring, we still have people with H1N1 coming in. along with the COVID pandemic. So can you really treat ill patients only on the basis of imaging patterns?
I mean, I have no hesitancy in saying that we also don't know the answers to these questions. And this is definitely an unknown, because, when you have a characteristic imaging pattern, then you generally rely on excluding what you can exclude. What all can be known, at least you try to exclude that and make a working diagnosis and then treat. And I definitely was not involved in some of the frontline decisions in some of these patients. And unfortunately, or rather fortunately for us, we haven't done that much of CT imaging. And then, so which means that the characteristic imaging patterns with COVID negativity was not as big an issue here as you probably have been facing. And I'm going to turn this question around and request you, since you yourself are highly accomplished thoracic radiologist, what is your experience being, Dr. Balla?
Yeah, so what we do advise is to run through a full viral panel and see if we can identify anything. We do ask for repeat RT-PCRs, but if consistently the RT-PCRs come negative, we have not been treating empirically on radiology basis because, especially in the immune compromised, so we are not using basically remdesivir or specific drugs unless we are able to get microbiology support, although we keep fishing for it repeatedly. But it's, patients come in late and we may have lost the window also of getting a positive test, which may be the reason, but we don't use specific drugs. And my second question is that there is so much emphasis on angiopathy now, and all the studies which show us images out of angiopathy, not just from pulmonary embolism, show images of DCT, So in a patient who is deteriorating and unexplained, say by chest radiograph and lung ultrasound, it's always a dilemma whether to go in for an NCCT or do you think you should go in for a CTPA, say in absence of an obvious positive DVT scan on the bedside, which would typically have looked at the large veins only, and borderline elevated D-dimers, like NCCT versus CTPA. How often would you take that call?
So again, there are three important aspects here. One is you have diffuse alveolar damage. Then you have a subphenotype of diffuse alveolar damage with microangiopathy being a predominant, driver of lung disease, in which you will start noticing microthrombi within the lung itself. Whether they are platelet microthrombi or fibrin microthrombi, they are at the capillary level in the lung. And then the third category is a procoagulation disorder of the entire system, meaning not just confined to the lung, but the individual becomes more prothrombotic, almost like disseminated intravascular coagulation type of scenario. So those individuals, this third subcategory, are the ones which manifest with large pulmonary emboli, and which is what we are trying to chase and trying to treat, because those are treatable. Whereas fibrin microthrombi and microthrombi in the capillaries, they are inherent to the etiopathogenesis of ARDS. I don't think using anticoagulation has really been shown to change the outcome of this second phenotype. Obviously, if you use anticoagulation, the generalized prothrombotic situation might be averted. But if there is no generalized prothrombotic process which is happening, and which can only be guided by a referring provider, because the referring provider is in a better shape to assess as to whether they're dealing with DVT outside the lung, or DVTs which eventually can lodge into the lung parenchyma. So which then brings us to the question as to how do you decide whether it should be, whether this particular individual has, has a high risk for pulmonary embolism, and then which brings us to the modified Welch score. You have to use the Welch score and then use that, or maybe if the D-dimer levels are too high in the current COVID-19 situation, you might go down the path of doing a pulmonary embolism study. I think there is a lot of confusion between a prothrombotic process, which is inherent to ARDS, versus a generalized prothrombotic state that some individuals with severe COVID experience.
Thanks,
Sudhakar,
Sudhakar.
We take you away from evidence-based medicine and risk you having to gaze at the crystal ball and say, when is this pandemic coming to an end? Are you going to take that risk?
No, it is tricky. I think it really depends on. I think it might change after I'm going to make a political statement here. Once Donald Trump steps down, I think it'll automatically fall in place.
We dare not even make a statement like that. And so, Sudhakar, there's a question on the chat box from
Sure.
Ananya. She's thanking you and that she enjoyed your talk. And she wants to know that, have you experienced combined cardiac and thoracic involvement in your patients?
Yeah, here's a limitation that I have, and I often joke with my residents that I'm a heartless lung person. So there is there have been several reports of cardiac involvement, and one of my good colleagues, Karen Ordovas, before I started this talk, she offered to give me some images of involvement of heart by COVID-19. Yes, it is known, and we have seen some cases where this has happened.
Chandan, do you want to ask anything? I can see you have put.
Yeah. Hello, Dr. Sudhakar. Good evening. So,
yeah, hi.
So among the, like you have described, three phenotypes. So among these three phenotypes, which one is likely to develop post-COVID fibrosis? So are you working on any prediction-based models regarding that?
No, we are still in the phase of binning these particular images or CTs that we have, and then the time has not lapsed enough for us to actually see that particular post-COVID lung fibrosis numbers to come back to us yet. So I think we're still following these patients, and interestingly, or unfortunately for this particular situation, we haven't done that many CT scans here. So I think maybe if there is any data available in India, maybe look at that and then try to do this. I think this is a ripe area for research. And then correlation, it might also help even before you wait for that. These imaging phenotypes might also predict which ones are the vascular subphenotypes of ARDS and which ones are going to be the vascular subphenotypes. And I think dual energy CT seems like a little bit far-fetched and exploratory, but if you have any examples, I think looking into that just from an academic perspective might be useful too.
Thank you.
So I'm going to read out a question from the YouTube chat box, which Ravi from Mumbai, I assume, has asked. Ravi, it's not very clear to me but what you're asking, but I think I get what you're saying. I think what he's saying is that when you see post-COVID patients and you see an ILD, and how do you know whether to label it in the ILD classifications, or should we label it as sequelae? particularly the subpleural basal pattern. We saw it in a lot of OP in COVID, and then eventually we assume it's going to lead to fibrosis in that area. And so it is really a challenge to know whether this is ILD or does it pre-exist, and the COVID just brought attention to it, or did COVID bring the fibrosis on?
That's an excellent question. And, my son recently, he asked me to explain what epigenetics means. And I didn't know he is an 11th grader, and I didn't know how to explain it to him in a very simple term. So I just told him, I gave him what I think was a funny example, that we have eggs in our refrigerator, and then we have a stove, and we have a cooking pan. I think the way these things work is, unless you bring the egg out of the thing and put it on the pan and cook it, you're not going to get an omelet. Which then brings us to this question is, individuals who have developed lung fibrosis, did they always have a predisposition to develop eventual UIP-IPF? But they did not have that milieu to develop lung fibrosis. And COVID-19 has only brought this subgroup of individuals or have made them at risk for developing a UIP-IPF type of lung pattern. And so needless to say, either the pattern of lung injury, the type of lung injury will determine who will eventually develop lung fibrosis, but then the inherent predispositions of an individual, whether it be genetic predispositions or the other host factors which generally lead somebody to respond to lung injury with lung fibrosis. Those are the ones which are going to determine. And unfortunately, we have moved the egg and we put it on the pan, and we have to wait and see which ones of them are going to evolve into a problem. I hope that answer was clear enough.
Yeah, so
we all read the very hard-hitting editorial in NEJM that came out recently on this issue. Any quick comments on that?
I think Dr. Ganesh Raghu would be a better person to answer, and I myself have limited knowledge in that area. But what were your thoughts?
This is the editorial that talked about how the US politicians handled COVID.
Oh, okay. So yeah, I think it is a strong political statement that the medical community made, and so everybody is feeling troubled by it, and not by the editorial, but by the fact that there was lack of leadership during this particular pandemic.
Ashu, you want to wind up?
yeah. So we have a few more questions left, Sudhakar. If you will give us the liberty, we will send them on mail to you, and
Sure.
we'll post the answers back on YouTube. Ravi, Pavan, Kiran, whatever points you have raised, we will get back to you on the YouTube, and we will in continuity tomorrow post the answers to this question, because we need to wind up now. This is a time-bound event. So, primarily, I want to express my thanks to Sudhakar and to Anoop's family and to the huge community of AIIMS Radiology, which we did not know also. We were such a large family. I'm really indebted to all of you for having logged in to bid farewell to a dear student, or to a dear friend, or to a dear colleague, whatever it may be, to express to Anoop's family that we stand in solidarity with them, and how we handle our grief and process it is by doing what we do best and what was close to him, which is discuss science and try and find solutions to the ongoing disease. I'm immensely thankful to everybody who has logged in today. And as I said, particularly to our AIMS Radiology family, AIMS family, and Radiology family. Thank you very much. And we will post those answers tomorrow.
Thank you,
Navdeep,
Sudhakar.
sir.
Thanks again.
Thank you. Thanks a lot.
Thanks,
Thank you,
Sudhakar.
Dr. Sudhakar. Thank you.
Thank you, everyone, and bye-bye.